All right, docs, the key to a low back examination is you want to be very thorough. This is our bread and butter, docs. This is what the public identifies as is the spine specialist. And so you got to be good with the low back if you want to have a successful chiropractic practice. So when you do your exams, make them flow, do them in the order of where their position is. So do your standing, and then you're seated, and then you're supine, and then you're prone. So I always start my low back exam from the standing position, and things I observe in the patient are many times I watch them walk. Sometimes as they're going back to the exam room, observe their gait and look for any types of postural abnormalities in their gait, especially observing for the 5 red flags of pronation, which are fallen medial arches. You should be able to put your fingers underneath their medial arches, a little ways anyway, and if you can't, that's a strong indicator of pronation. Another strong indicator would be if they have external foot flare, especially when they're standing or when they're walking. Turning around now, all the way, you will see that they have bowed medially Achilles tendons. That's a strong indicator of pronation. Turn back around again. And you will also see, if you line up their feet to their knee, a lot of times they'll have medial rotation of the patella. And the final thing is, look at their shoes. Look at the outer heels of both shoes to look for lateral heel wear. People usually that have excessive pronation have lateral heel wear, one worse than the other. So they have usually bilateral but asymmetrical pronation. So then the other thing we do with all of our low back pain patients is we do a digital foot scan of them. And that will get both feet simultaneously. It will show how they bear weight side to side. It will measure the level of pronation that they have, and it will show if there are any imbalances in their arch height. Critical for a low back. Studies show wearing orthotics, foot levelers, what we use, will result in a 34.5% reduction of chronic low back pain just from doing that alone. So don't overlook the examination of the feet when you have the low back pain patient. We keep our patient standing, as then we go to the exam room and we do things like range of motion. So face this way, Noah. So I don't measure motion, but I visually inspect them from behind to look for deviations. And so we of course do a rotation each way and the other way, and asking the patient, does that hurt you? And if it does, have them point to it. Bending to the left as far as you can, bending to the right as far as you can, looking for restriction and or pain or both. Bend back to what you can, and of course bend forward far as you can. Does that hurt you? Are there any restrictions in that motion? I always then go into my Kemp's test, and I'll do that sometimes both seated and standing, but I always do it standing for sure. And Kemp's test is a really important test. We're going to bring you back here a little bit, Noah, to look for facet syndrome, of course. Most of the time with this, if there's active facet involvement, you are going to have some degree of localized low back pain, with sometimes it'll radiate one way or the other, but it's a very strong indicator of lumbar facet syndrome, which is one of the more common diagnoses, doc, as you well know. And then of course, observe their overall posture. We've already looked at the feet, look at iliac crest heights, look at shoulder height, look at the heights of the ears from side to side, and then looking at them, turn face that way, looking at their posture from the side, anterior head carriage, forward tilt to the pelvis, things like that. So those are the big things that you want to do, folks, when you're doing your standing examination. And again, don't forget those feet. All right, docs, on to the seated exam. There's 3 or 4 really important tests to do from this position that can help you to see if there are nerve root problems in the lower back and from disc or other things. So first one I always do is Bechtereau's test. So Noah, straighten out your leg. And of course you're looking, does that reproduce their low back pain, but especially does it reproduce if they have radicular pain, any of their leg symptoms. And then from there, bring that up again, Noah. Tuck your chin down, and I have them lean forward, and this is called slump test. And that is probably the best test that you can do to look for sciatic radiculopathy. And that test really puts a lot of extra pressure on the intervertebral disc. If there's a bulge or herniation, that test will usually bring it out. If that doesn't bring it out, bring that up again, Noah. Tuck your chin, go to slump, and now take a deep breath in, hold it, and then bear down like you're straining at the ball. That is a combination of slump with Valsalva maneuver. Usually one of those three tests will bring out the disc lesion if it is there. Vectoruse does not put as much strain on the disc. Slump is more, and combining the slump with the Valsalva, that's the most high tensile stressor on the disc and the nerve roots there. So kind of do those in order like that. The other thing, so you do that on both sides, obviously, and then of course, take your reflexes from the seated position, your patellars and your Achilles, because they're strong indicators. A lot of these people we're working with have disc problems if they're coming to us, and we want to look at them neurologically. So those are the big ones to look at from the seated lumbar exam. All right, we're now to the supine position, and I continue my neurological exam that I just left off with the reflexes, and so I'll go to motor exam. You know, the big three to test are L4, L5, S1, so Noah, hold your feet in like that. Don't let me push them out. Let them go out. Don't let me push them in. There's L4, then we went to S1. Now hold your big toes up. Don't let me push them down. L5, okay? We always then go to sensory examination with bilateral pinwheel, and we're asking the patient to note that this should feel roughly the same from side to side. So we go up the inner ankle for L4, bilateral big toe for L5, and outer ankle for S1, okay? Of course, if they have femoral symptoms, not sciatic nerve, you can do those same pinwheels over the thigh for L2, 3 area. And you also can do additional muscle tests up higher if you need to. Hold your leg up, no, don't let me push down, don't let me push your foot down. You can also do tests for other nerve roots lower down. Don't let me push your leg out, let your leg come out, don't let me push in. If you think there's more than one nerve root involved, you might have to do more muscle testing than just down here is all I'm trying to say with that. But for most people, L4, L5, S1 is probably going to cover most of what you need. And same as the sensory exam down in the ankle and foot area. So reflex, motor, sensory, especially anybody that's got leg symptoms, that should be part of the exam. Then I always include one other nerve tension test. I always do a straight leg raise. And always note if whatever degree that the test is positive. So if they were about here, I'd say that's positive at about 45 degrees. And always ask how far down the leg does it travel. The other test that you want to do from here is one of the best sacroiliac tests, which is called Gainsland's test. Scooch over a little bit to the side of the table, Noah. Draw this knee up towards you, grab it. Now we're going to bring this leg off. We're going to let that fall down. Then you push up here and down here. The side down is the sacroiliac joint you're stressing. So if this increased their right SI area pain, that's a strong indicator of sacroiliac dysfunction. Scooch over that way for demonstration, Noah. Come over this way a little bit further. Draw that leg up towards your chest, grab it, bring the leg off, and that is a good, well-researched, very sensitive and specific orthopedic test for the sacroiliac joint. And then I also screen always for hip involvement. So do your typical Patrick Faber position and see if that causes any hip pain. A lot of patients with lower back issues have underlying hip dysfunction, and you want to rule that in or out. That is the main things you want to look for from the supine position with the lumbar exam. Finally, get your patient in the prone position and finish up with a few other tests. So there's a couple other SI joint tests I like to do besides Gainsland's. So one of them is Hibbs test, placing pressure over the opposite SI joint and bringing the leg out. If there's sacroiliac dysfunction, it a lot of times will reproduce their pain, and of course doing that bilaterally. And then the other one is Yeoman's test, where we lift under the knee, pressure over that SI joint, and bring it up. Most commonly they just feel stretch in the hip, but you're looking for a reproduction of sacroiliac joint pain. Other things to consider from this is always then I palpate the spine for a specific level of misalignment or subluxation. Palpate the relevant anatomy, that's the bottom line. Feeling the muscles for tone and texture and spasm. Obviously with sciatic nerve involvements, palpate those piriformis muscles, TFL, the erector spinae muscles. And I always get right along the spine and really palpate those facet joints and the multifidi muscles that connect to those areas. And finally, there's just some other things that you may want to consider as you finish up your exam. Does this patient need an x-ray? And that's up to your best clinical judgment, doc. But if they have radicular component, leg symptoms, generally it's a good idea to get at least a minimum of an AP and lateral x-ray. If you find on the x-ray they have a spondylolisthesis, it's not a bad idea to get flexion and extension views to check for instability. And then of course you have to weigh the possibility, does this person need an MRI if they have not had one already? Thankfully, a lot of patients that enter our office with sciatic nerve involvement, and by the time they're looking at maybe a decompression, laser, things like that, many of them have already had the MRI. But if there are significant neurological symptoms and maybe there's been some conservative care done already, it's not a bad idea to go ahead and get that MRI. But in most cases, I'm confident with the exam we did and a good set of x-rays to at least begin care if they've not had an MRI. And if their condition is not showing improvement in 4 to 6 weeks, at least 50%, that's the time to really start thinking about ordering additional imaging with the MRI. Bottom line is, folks, if you do that thorough of an exam, you're going to rule out you're going to figure out what the pain generator is. Is it a disc? Is it the facet joints? Is it sacroiliac? Is it a combination of all those things? Is there hip joint involvement? Do the feet contribute to the low back? And by doing that, you're going to have a really good idea of how to address this patient's condition and what their root causes are. So that's the type of a thorough exam you need in order to really take on these challenging cases of low back pain. And once you become good and efficient with it, shouldn't take you more than 5 to absolute most 10 minutes. And then final thing, docs, always get an outcome assessment. So we do a back index and osseohistory, that type of thing on our patients. Track your results with these patients and know how their condition is affecting their activities of daily living. So these outcome assessments are important to do at the beginning of treatment and maybe halfway through and then again at the end to monitor their progress. And a lot of times the patients will say, well, my pain's not a lot better, but then when you do their outcome, they can walk better and they can stand longer and they can sit longer and things like that. So then you show them their scores and like, oh, I guess I am getting better, doctor. So they're important to do. Track your results with these patients.